Pulmonary edema is a condition in which fluid accumulates within the normally air-filled alveolar space, resulting in impaired pulmonary gas exchange. This usually results from increased hydrostatic pressure in the pulmonary venous circuit. The most common cause associated with pulmonary edema is left ventricular failure, or LVF in short. In left ventricular failure, there is reduced ejection fraction with increased end diastolic volume and cardiac preload. The pooling of blood and increased preload causes an increase in left atrial pressure and pulmonary venous pressure, and consequently increased pulmonary capillary hydrostatic pressure. The increased hydrostatic pressure causes increased net filtration of water out of the capillaries into the pulmonary alveolar space. Common causes of LVF include myocardial infarction, cardiomyopathies, and myocarditis. In addition, cardiac arrhythmias such as atrial fibrillation, ventricular tachyarrhythmias, and heart blocks may cause reduced ejection fraction and pulmonary edema. Dysfunctional mitral and aortic valves may also contribute to pulmonary edema. The obstruction of blood from the atrium in mitral stenosis or the left ventricle in aortic stenosis can lead to back pressure to the pulmonary vein with increased pulmonary venous and capillary hydrostatic pressure, causing pulmonary edema. Non-cardiogenic causes can also cause pulmonary edema, but it's important to distinguish it from cardiogenic causes. In cardiogenic pulmonary edema, the fluid collection in the alveolar spaces is a transudate composed mainly of water. In non-cardiogenic edema, there is damage to the lung parenchyma that causes increased capillary permeability and escape of not only water but also plasma proteins and inflammatory cells into the alveolar spaces as an exudate. Non-cardiogenic exudative pulmonary edema is seen in conditions such as acute lung injury and the associated acute respiratory distress syndrome. Occasionally, pulmonary edema, which is transudative, may also occur in the presence of cardiac decompensation due to intravascular volume expansion, as may occur in chronic and kidney injury, transfusion-associated circulatory overload, and in severe hyperproteinemias. Pulmonary edema is associated with characteristic histopathological changes resulting from the obstructed pulmonary venous flow, causing increased pulmonary capillary hydrostatic pressure with collection of fluid in the alveolar space. In histopathological sections, you will observe widened, engorged, blood-filled pulmonary capillaries and veins, which is referred to as congestion. The alveolar spaces contain homogeneous eosinophilic material, which is the edema fluids that collect in the alveolar spaces.